Is it clear? My background is clear?
Yes, yes. Everything is clear. Asma, you can start.
Okay. Thank you, Dana, and thank you, everyone. I would like to welcome you all today to Infinite's WEBi series. My name is Asma Khanas. I work with the Public Health Emergency Management Center at GHD Infinite. We gather here today to shed some light on a very pressing issue, which is the Sudan crisis and its profound impact on health. Sudan healthcare system, as we all know, is facing severe challenges with hospital damage, limited medical supplies, and limited access to essential services. This crisis disrupted preventive measures, primary healthcare functions, and immunization programs, and so many other programs, which puts the population at a high risk. Of course, urgent humanitarian access is needed for more than 15 million people currently in Sudan. And for that, we have our webinar today. We aim through this webinar to provide an update on the health status and the interventions by the Ministry of Health and other partners, as well as we can highlight the required support currently from international partners. So allow me to introduce our first speaker, Dr. Dalia At-Tayyib. Dr. Dalia is the Director of the Primary Healthcare Directorate and the Maternal and Child Health Director at the Federal Ministry of Health Sudan. She is a public health professional with a medical background, and she has a Master's of Public Health from the University of Cape Town, South Africa, with Sexual and Reproductive Health and Rights Fellow at the University of Lund, Sweden. She's an expert in maternal, reproductive, and child health, health policy analysis, and quantitative research. She worked previously in several posts that include quality improvement of maternal and child health services, implementation research related to gender-based violence and respective maternal health, and surveillance at the Federal Ministry of Health and international NGOs. Dr. Dalia, please go ahead with your presentation. Thank you so much for your participation with us today.
Good afternoon, good evening for everyone. I'm happy to join this technical webinar and to speak on behalf of my beloved country and my beloved population. My heart really aches me on what's happening in Sudan, and I will provide overview on what's happening on the ground right now, and that would be complemented by what would be presented by Dr. Al-Mughira and Dr. Ali. I think most of the presentation will be around the PHC and the PHC programs. My presentation outlines will cover the overview on the current situation, the impact on the health system, the immediate actions on governance and coordination, impact on health service delivery, and the contingency planning and fund, challenges and opportunities. As you may know that since 15th of April, Sudan has been ravaged by a brutal war between the country's two main military powers, the Sudanese Armed Forces and Rapid Support Forces. In fact, these are two main forces that are meant to protect us. Active military operations in Khartoum State and West Darfur, plus some eruptions in South Darfur, Central Darfur, North Darfur, and North Kordofan have been happened all over the last 63 days. As of 17 June, at least 1,081 innocent civilians are being killed in the crossfire. This, according to the EOC, FMOH EOC report, and nearly 2 million people have been displaced to safer places inside or outside. A quarter of them, they are across the border of Sudan. The bulk of that is in Egypt, around 216,000, and then to Chad, South Sudan, part of them in the Central African Republic. The impact on the health system, mainly the health system before the war is not in optimal situation, is severely affected by the war. Even the state which there were no conflict on it, affected by the IDPs coming from war area, and loading those states with unexpected number of patients. The central warehouses are currently besieged, which substantially affect the national medicine supplies, especially the HIV, TB, malaria medicines within and outside Khartoum state. The supply fund in Darfur state was burned out, leading to a total loss of medicines stock there. The National Public Health Lab also occupied by the militia groups. The immediate actions been taken since the 15th of April. FMOH on the same day, the day of 15th of April at 5 p.m. declared that national health emergency in Sudan. On the third day of the crisis, there were an activation of all health emergency response committees at all levels, at federal level, at state level, including also a subcommittees for treatment and care, and also for supply and logistics and so on. In the fourth days of the crisis, there were a formulation of high interministerial crisis cell that mainly support FMOH on facilitation of health needs and procurement and supply and logistics. Master list of needed supplies and medicine were developed on approximately on the day 10 and shared with all partners. Due to interruption of the banking system, the Federal Ministry of Finance supported FMOH with alternative means to ensure cash availability to MOH. National Medicine Poison Board, National Medicine Supply Fund, and the FMOH Finance and Financial and Administrative Departments are all working as one committee in the Port Sudan since the second week of the crisis, and this system up to date managed to facilitate 26 international shipments and support the country response. Zonal PSM hubs are now functioning from Madani, Kosti, and Al Ubaid. At the beginning, it was Al Ubaid, but now it's Kosti until the situation in North Kordofan de-escalate. Adbara and Port Sudan. National Public Health Laboratory is currently in preparation to resume its mandated function from Port Sudan. Procurement plan of the Biosafety Cabinet and other important supplies is finalized with WHO and Ministry of Finance are working on availing the needed financial support. And the Federal General Directorate, FMOH General Directorates relocated to alternative state as a ministerial decree from His Excellency Dr. Haytham. Three cities have been determined, identified to for the general directorates to be relocated to. For example, in Red Sea, the National Medicine Supply Fund, National Medicine Poison Board, Blood Transfusion Services, Public Health Lab, and Finance and Administrative Department will be in Port Sudan. In Jazeera State, the Curative, the PHC, Pharmacy Directorate, and International Health, and the ACA. And the River Nile State in Adbara will be the Health Emergency and Epidemic Control, the Quality and Accreditation Directorate, the Medical Commission, and the HRH, Planning, Policy, and Occupational Health. These relocations have been identified, the alternative state, based on the feasibility of the core staff to relocate themselves in the new station, and also suitability of the, or the capacity of the state to work for a mandated function for the General Directorate. In Khartoum State, there is a very well or very good implementation arrangement where the communities themselves supporting the most of the health response. There is a locality emergency response rooms in the 7 localities, and they are very active in supporting the Ministry of Health in full collaboration with Ministry of Health in terms of availing the medicines and transporting the staff and using their connection to even find the safe corridors for the staff to be in and out the health facilities. And also they are also represented in most of the health emergency response committees. There is a phenomenal support. Actually, there is too many very good story to be delivered. There is a phenomenal support received from different community entities, especially the resistant committees, significantly aided ensuring service continuity. They are mobilizing resources to avail medical supplies, fuel, logistic needs, and also support health facility staff, transportation, and food supply. But also they are transporting patients, women in childbirth to health facilities. Also, diaspora and the Sudanese Doctors Association abroad extended their usual support, the technical support that they are mandated to coordinate and facilitate huge medicine and consumable supplies. Also, there have been a very good support received thus far from the NIPOR's countries, and it's highly commendable, as well as support from the UN agencies, the Red Cross, Red Crescent, and Medicine Sans Frontier. The impact on health service delivery is huge, and currently the Federal PHC Directorate and its public health program are working from Jazeera states, with exception to HIV and TB. They are functionally working from Atbara. Access to emergency and acute health service is very limited, as most of the tertiary and specialized care facility are not functioning, either due to unavailability of electricity, staff, medical supplies, or are occupied by militia group. But also there is no safe corridors to the majority of the health facilities, but I think Dr. Al-Mughira will elaborate more on this point. Ministry of Health in 12 states now is working at its full capacity, namely Northern River Nile, Sinnar, White Nile, Blue Nile, Gadaref, Kasala, Red Sea, South Kordofan, West Kordofan, and East Darfur. Also North Darfur were in and out in the full functionality of the MOH management working. The main obstacle for providing the service delivery is availability of the supplies. In active military operations area, for instance in Khartoum, PHC centers were more resilient and were backed up. Hospital went out of service most of the time. Also, the implementation model of locality emergency response rooms help a lot in supporting instant relocation of the PHC centers within the community, and when the military operation increase in the area. Like, for example, some PHC centers in Khartoum, sometimes for 3 or 2 to 3 days, they are working from within the houses within the community, and then when the situation de-escalate, they go back to their usual sites. Also, redistribution of staff and commodities between the functional and non-functional PHC centers have been facilitating through this arrangement. All servers, unfortunately, health information and logistic information are not functioning. All servers are shut down. However, a rapid assessment of health information system functionality was done. A plan to regain DHIS2 functionality was developed with support from HISP Rwanda for hosting, and DHIS2 is now functioning since 2 days ago. I will go briefly on the PHC programs. For example, I'm very sorry on that. The reproductive health program, it was sorry, I just would like to take this out. In Khartoum State, during the early days of the crisis, FMOH led to arrange for community and home childbirths, were distributing vital supplies through the locality midwife chief, the midwifery supervisors at the locality, who are responsible for hundreds of midwives in each Khartoum 7 localities. using the main social media platforms at that time before these connectivity issues. We succeeded in broadcasting essential messages to communities through the contact of the nearest midwife and midwifery supervisors. And this system was crucial in the successful management of thousands of normal and uncomplicated deliveries. Access to emergency obstetric and newborn care is limited, and currently only 8 maternities are functioning in Khartoum, with other facilities in and out service. Most of the complicated deliveries are now arranged either in the facilities located in the state periphery or referred outside Khartoum to the nearest locality, for example, to Kamlin or Hasahisa, or even to Shendi and so on. Also, Dr. Al-Maghira can elaborate more on this curative part, but also there is a main obstacle related to the clean delivery kits and the RH kits. They are locked in the National Medical Supplies Fund, where the militia group are occupying it. On immunization, I think immunization EPI program was one of the most resilient programming compared to other PHC programs. Early, they are relocated themselves, and they start working on delivery or distribution of the quarter needs of vaccines to the states. Now, 12 states received their vaccine for 3 months, and this was done with UNICEF financial and logistic support. And also, despite the long electricity outage in Jabra, where the national cold chain store located, I think Jabra now is main battlefield location. FMOH with logistic support from UNICEF, we managed to keep the fuel support, the fuel availability on hand. Like also on the day of 15th of April, it was very good that EPI maintained the preparedness plan on having 15 barrel of fuel at that day, and it was very good to sustain the electricity for, I think, the 10 days, the first 10 days of the crisis. After that, I think we keep arranging with UNICEF to have a continuous fuel supply. Darfur and Khartoum state vaccines are secured in the Central National Store, and there is a plan for relocation to the alternative cold chain. Already Kassala and Gadarif and also Sinja have been identified as alternative cold chains for the national cold chain, and also the Port Sudan cold chain to be like a first receiver of the international shipment. The central cold chain of the West Darfur in Janina unfortunately destroyed and burned, and we lost all the vaccines there, and we lost around 26,000 MOBV vaccine that have been a residue from the first outbreak response to the CBBD. In Miala, looted, the cold chain was looted, but no harm for vaccines happened. Vaccination service continued in Khartoum until May, mainly in Khartoum peripheries, in the peripheral of the peripheral health PHC center, but also in the Buluk Hospital. Buluk Hospital in Omdurman was main pediatric hospital working during this crisis, and they were providing vaccination services until the first week of May. After that, unfortunately, we did not manage to predispose vaccines to the hospital. However, with this long electricity outage and security difficulties, the immunization and vaccination service in Khartoum now is not functioning. On nutrition program, services were severely affected by these war and conflict areas. However, 90% of these stabilization centers, 93% of OTB, and 66% of the TSB are now functioning all over the Sudan, with exception of Khartoum, because there are only 4 nutrition sites are now operational in Khartoum. The 2 sites in Jabal Awliya indicated rapid significant increase in admission in OTBs between April and May, and I think Dr. Ali will elaborate more in this nutrition support, because we just received, I think 20 metric ton, and also, sorry, we just received stabilization centers supply and commodities from WHO. On environmental health, vector control activities are now provided in Port Sudan and Jazeera. IRS conducted in WEBi locality with a residue of the insecticide from the last IRS campaign, and are mainly located around the IDBs, where the IDBs is located. And larva source management in Port Sudan with support from WHO will be launched next week. The special case of Jazeera and Sinnar being not covered with the usual vector control intervention IRS poses a high risk for the inhabitant of the two states. I think one of the main priority is to find out how we can support Jazeera and Sinnar with this very important intervention. IVM plan that cater for the rainy season are developed for all states and have been and now Minister of Finance gave us the approval to go on the deals with the suppliers. WASH campaign in Wadi Halfa launched last Thursday around the two port location around Ashket and Argin, but also in the IDB's camps. With support from UNICEF, WASH campaign in Tuti, Iceland is now under process. On the mental health, I think this war, the mental health has become a top priority and urgent need for psychological support at all IDBs and all, specifically for children. Rapid assessment on the current situation, especially in the IDBs, camp and shelters, was conducted in early May. Plan on providing psychological and special and social support services developed and shared with the states. The Jazeera state has 18 camps in Madani. I think 60 camps, but there is 18 camps prioritized for mental health activities. Training on parenting tips and psychosocial support and the interagency minimum service package have been implemented in Jazeera, White Nile, Port Sudan, and Northern State. West Darfur, unfortunately, could not provide any service due to the difficult security situation there. On the surveillance and outbreak detection, I think I will just give a brief. Dr. Ali will complement this information and will even provide further information on it. In the affected state, the system is not functioning because of insecurity. In case of clusters of suspected cases, an outbreak confirmed based on the likelihood of epidemiological analysis. In the states not affected, the surveillance system continue to operate, whether facility-based surveillance or community-based surveillance. The system is fully functioning in terms of reporting, investigation, sample collection, storage, but the main challenge is the testing because of the non-functionality of the public health laboratory. For the AFB surveillance, because as you know that Sudan implement a first outbreak response campaign on March, but unfortunately the second campaign that should I think that was due in 8th of May. Unfortunately, it's not implemented, and it's critical to monitor the AFB in Sudan. The samples now in Dongola and in a way to transport to the regional lab in Cairo. National Public Health Laboratory, as I've said, it will be resumed in Port Sudan with a collaboration between also with Blue Nile Institute in Jazeera, and also for the vaccine preventable disease surveillance. We also identified Al-Ubaid as a zonal lab for Kordofan and Darfur states. Already assessment for the 3 labs have been carried out, and the list of the supplies and consumables have been shared with the regional office in Emro. Outbreak response to measles with vaccination and vitamin A distribution in Blue Nile has been successfully conducted in Wad al-Mahi locality. Malaria outbreak continue to be monitored. Movement of population from low malaria endemicity to the high endemicity area and vice versa possess a great risk for malaria outbreak with higher incidence of severe malaria and increased mortality. And I think this is one of the main worried for all of us right now, that Jazeera and Sinnar, with people coming from Khartoum and also North Darfur, for people coming from West Darfur, there is a case of the high endemicity to people coming from low endemicity to high endemicity area. It's one of the main worried for all the FMOH and partners right now. In terms of the HRB health contingency plans and funding, also Dr. Ali will provide more information on this point, but on general, only 15% out of the 2.6 billion is funded to date to cover the revised HRB plan for Sudan that aimed or mean to reach 18.1 million population. The health component of this HRB is 178 million USD, and up to now only 20 million have been, I think 11% have been dispersed. The Directorate of Emergency and Epidemic Control compiled all the response plan from the directorates, other directorates, and shared with the partner. An urgent need plan have been submitted to the Higher Crisis Committee by His Excellency last week, and the reprogramming of the existing grants such as HSS from Gavi and GC6 from Global Fund have been done and approved by the donor. A high level pledging event to support the humanitarian response in Sudan conducted yesterday by a friend of Sudan, and they announced 1.5 billion for support to the Sudan. The challenges, I think I have mentioned most of it. The continuous military operation in Khartoum and Darfur region with suboptimal implementation of the ceasefires, limited utilization of service mainly due to insecurity and limited access or absence of service provider and supplies, interruption of basic service to health facilities such as the electricity, the water, the banking system, and the communication networks, scarcity and high prices of fuel for mobility and alternative power supply, health facilities going out of service and back to the service are reported daily, making it very difficult for health seeking decision and also for authorities prioritization. National Medical Supply Fund, the central house is inaccessible. We already say that the stock for the 3 programs, TSH programs are 0. National Public Health Lab occupied by the militia groups, and all servers are down for health information and logistic information. But I think also there is opportunities here we need to be mentioned. I think one of those is the resilient communities. I think what are the heroic, the magnificent support from the communities themselves is phenomenal. People in Khartoum, they're providing their best and even they are risking their lives to support others. And I think we need to capitalize on this and to support more community participation and community engagement to facilitate or to support health on this time. Also, the movement of healthcare professions from the center to the state provide a good opportunity for strengthening the health system in those states and also strengthening the decentralization system. And also there is appetite now and like a mind set, it shifted to invest more in the regional development. Now Adbara already they have oxygen supply factory, and they are supporting the other state with oxygen supply, and also the relocation of a national public laboratory to alternative location will make more state resilient and strengthening the laboratory and diagnostic services. Sudan, also the Sudanese diaspora continue providing the technical support, and even their mandate now is extended to other functions. I think I will stop here and I will be until the end of this webinar, and I will maybe have more interventions during the discussion. Thank you.
Thank you so much. Thank you, Dr. Dalia. This was indeed informative in regards to updating us on the situation in Sudan, the impact on the health system and the service delivery, which seems to be heavily affected by this ongoing conflict. So thank you so much for the update. Maybe now I'm going to go to our next distinguished speaker to cover this area furthermore, to Dr. Al-Mughira Ahmed. Dr. Al-Mughira is a community medicine consultant who currently serves as the Director General of the Directorate General for Curative Medicine at the Federal Ministry of Health and the Senior Staff at National Health Insurance Fund headquarters in Khartoum, Sudan. He earned his MBBS from the University of Khartoum in 2001 and a postgraduate diploma in community medicine at Al Jazeera University in 2008, and a master's degree in economics and healthcare management from Chulalongkorn University in 2013. He is also a board certified, having an MD in community medicine from Sudan Medical Specialization Board. Dr. Al-Mughira networking also includes membership at the WHO Health Financing Technical Group, Joint Learning Network, Population Coverage Collaboration, Executive Board Member at the Afro-PHC and Community Medicine Specialty Consultancy Council at the Sudan Federal Ministry of Health. He also lectures public health subjects at several medical and health academic institutions in Sudan, as well as regionally at International Academy of Public Health. Dr. Al-Mughira, please feel free to share your screen and you have 20 minutes. Thank you.
Thank you very much, all audience. I greet you, and I would like first to deliver a great deal of thanks to Infinite for launching this very important event. And also like to extend my thanks to all audience today, and also to my colleagues, Dr. Dalia, Dr. Raja. Really this reflects that the real feeling of Infinite and all audience that feel toward Sudan crisis now. My presentation will be short because Dr. Dalia covered most of the topics that I will present, but I will concentrate mainly on the curative part, which is mainly delivered through the secondary and tertiary level. I mean the hospitals. This is the main of my presentation. So the outlines will be a short introduction, and I will talk briefly about the pre-crisis situation, then the impact on hospitals mainly, both in secondary and tertiary level, and I will mention some efforts that are exerted by a healthcare professional in Federal Ministry of Health as well as the State Ministry of Health in order to mitigate this effect or this impact of this devastating crisis on the health system. Then I will end with some challenges and urgent needs. As you know, we have like 18 states constituting the country of Sudan, our population around 42 million, and the health system is administered through three levels or three-tiered system, which is federal, state, local. The federal is mainly responsible for the policy setting, regulations, international relationship, and so on. Also long-term training for the medical staff and other health professions. At the state level, all the executive part of the healthcare system.
Sorry, Dr. Mughira, can you please show your slides in full presentation mode. Thank you.
Is it clear? I share my presentation, okay?
Put in presentation mode, please.
Is it clear now? Is it shared?
It's clear, Dr. Mughira, but you just need to put it in full screen so that
Okay.
everyone can see it in
Okay.
full screen.
Is it now? Is it in full screen?
Not yet, no.
Wow. I don't know why. Here it is in full screen in my computer.
Maybe if you want to stop sharing it and then reshare it again.
Okay. Is it okay now? Or
It's
still?
not in the presentation mode. If you'd like, you can stop sharing and we can share it from our side.
Okay, let me close it. Then try.
We will share it from our side, Doctor. That's fine.
Okay, okay.
Thank you. Just let us know when we should move to the next slide.
Okay. No. Go back, sorry. Yes, here. Regarding the hospitals, or before that, we are still in the health system. As I said, we have the state is responsible mainly for delivering the healthcare service because it's a responsibility at the state level. At the local level, the primary healthcare, including the health centers, including the curative and preventive parts, are the responsibility at the localities. And as far as the hospitals are concerned, we have around 560 hospitals in Sudan, including rural hospitals. Next. You go back. Regarding the hospital, most of the hospitals are public, as here shown by this diagram. Around 77% of the hospitals are run by the government. That's to say it's public. And 23% of hospitals located in Khartoum state. So around quarter of this number are located in Khartoum. This is why the impact of the impact of this crisis and this conflict affected the hospital more. Next. Before going to the crisis itself and its impact on the health system, I would like to take you a little bit back to show you the situation before the crisis or pre-crisis situation. Really, the conflicts add more to an already fragile system. And before the clashes, health system suffered a lot from severe shortage of financing. And I will be very frank and say that all the pillars of the health system are affected, including health service delivery, health workforce, information, medical products and technologies, financing, and also the governance. But the most affected part is the finance before the crisis, because I think the federal Ministry of Finance to a high degree failed to move funds from the Ministry of Finance to the Federal Ministry of Health. And not only the Federal Ministry of Health, because we have programs affected more by this shortage of finance, but also other partners like National Health Insurance Fund, like the National Medical Supply Funds, all of them are affected by this very shortage of supply. And to the degree that even the blood bags were witness very low shortage, to the degree that they were out of stock. I think this is a very extensive extent to have even the blood bags affected by the shortage of finance. After that, the next, sorry. After the 15th of April, when the conflict commenced, the impact on hospitals become very, very obvious, and we can divide it into direct and indirect. By direct, we mean that there is destruction of buildings. Some hospitals affected by this, like the Ibrahim Malik Hospital, in Nile East hospitals, and so on. Around 12 of the hospitals were occupied by the militia, and due to the insecurity, there was severe inaccessibility for patients and the staff. And also due to the shutdown of the banking system, so no reimbursement of the staff. And most of these hospitals also and other related facilities were receiving stealing of assets. And this mainly in the areas where the conflict, in the states where the conflict is there. And other impact is indirect, by which we mean the overload of the existing facilities, and this is mainly in other states, neighboring states to Khartoum. And also there was a very shortage of supplies and staff at these facilities. Next, please. The impact on hospitals also continues. The states are mostly affected directly are Khartoum state, West Darfur, namely South Darfur, Northern Kordofan, and Central Darfur. These are affected mainly because the clashes are there and conflicts are there. All other states are affected indirectly with Jazeera and River Nile state, and also White Nile state affected most, because as Dalia said, the overload of these hospitals due to influx of IDPs from Khartoum state affect these states mostly. And as I said, other partners like National Health Insurance Fund, National Medical Supply Funds, infrastructure, including buildings, IT system, automobiles, and medical stores, all are affected in these areas. Next. Also, there is impact on the service delivery in terms of, as I said, for injured victims, there is inaccessibility to reach the hospitals. There is shortage of staff and supply. All the ambulances, also there is ambulance restriction for movement because due to insecurity. For patients with non-communicable conditions, also this group of patients are affected most. There is shortage of long-standing medications. Patients on renal hemodialysis also affected because most of the, really all the centers for hemodialysis in Khartoum stopped from delivering the services. So also patients with cardiac problems, cancer patients, especially those on chemotherapy, and transplanted patients, all these are affected by the conflict in Khartoum mainly. Patients also on surgical waiting list, this another category which are affected most by the jeopardizing of the service delivery, like cardiac catheterization, cardiac surgery, organ transplantation, all these, and already all the operational list is stopped in all hospitals in Khartoum. Next. So due to that, there are efforts are exerted. I will just highlight some areas that the healthcare professionals at federal and state Ministry of Health, they exerted efforts in order to mitigate this crisis and mitigate the impact of this crisis on healthcare service delivery. First of all, the information management system, as I said, is affected. The service delivery also is affected. Supply management and administration and networking. These are the areas where the efforts are exerted. Next, please. So in the information system, as it says that the system, as said by Dalia, is all are shut down, but we managed to create like group working virtually through WhatsApp, through Facebook, in order to have some sort of communication, sharing ideas, sharing the reports. So the main group, including Federal Ministry of Health staff and DGs of State Ministry of Health. So this is what was one of the early interventions that is made in the early phase of the conflict, so as to have like a hub for the information to reach the Federal Ministry of Health. For that, we designed a report template, including the main important indicators for the current situation in each state. So we received this on regular basis, and what is shown by Dr. Dalia in the few past minutes was part of this. Next. Also in the healthcare service delivery, we managed to run and sustain the services in 16 hospitals in Khartoum. Most of them are in the peripheries. So they also absorb some of the shocks, because like we have like Turkey hospital in the southern part of the state, and Sororab and Jazira Slany on the northern part, Banjadid in the eastern part, in the East Nile locality, as well as the An-Naw and Al-Buluk hospitals in Durman. In addition to some rural hospitals like Al-Ilafun, Abu Dhabi, which to some degree absorb most of the patients that need ordinary services or outpatient services and so on. But most of the hospitals, you can see that this 16 out of 130, this is like 10% only of the capacity of the healthcare service delivery in Khartoum. But also regarding other states, we managed to re-establishing the services at Niala, which is the capital of South Darfur, and Zalinji, the central Darfur capital. These are the main hospitals that in the state were affected first by the conflict, but later on they enter the services. Also, we did great efforts in relocating patients with non-communicable diseases to specialized centers at neighbor states like Jazira State, and mainly Jazira State and River Nile State, in addition to the Northern State and White Nile State to some degree, especially those on renal dialysis, those with cancer, on chemotherapy. We could manage to relocate them there, redistribute the services there. But you can imagine how these centers were overloaded with the patients. Next. Also, we managed to activate and promote different voluntary medical specialty associations for online consultations. And here I would like to deliver a great deal of thanks to all the medical associations in Sudan for their great support also for the system by early intervention, by making themselves available for such online consultation through WhatsApp, through Facebook, and so on. And also we activate different specialty committees to avail the service to NCD patients. Like we have a cardiology group, including most of the senior cardiologists in the cardiology consultant committees at the Federal Ministry of Health, like the oncology specialty, also the committee of gastroenterology, because also they have patient transplanted and other patient needed some services. This represents like a hub for sharing ideas and promoting the services and having some instructions to the facilities in the state. So also they exerted a lot of efforts to make these services available for the patients. Next, please. As far as the supply management is concerned, I think Dr. Dalia covered most of it, but we managed to receive and distribute medical aids donated from different countries and agencies from Port Sudan, the Port of Sudan, to different regions and different states in Sudan. And also would like to greet all the staff who work really in a very, very tough atmosphere, and they managed to handle all these items to the end user at the hospitals. Or next, please. As far as administration is concerned, also we managed to create different working groups from the administrative staff to fulfill some tasks. They work on daily basis. People meet and share and exchange some ideas regarding the administrative parts. Also, we benefited from the existence of some staff members in some states to work from there. For example, people from in Jazeera state, most of them from the curative department. So we managed to have the staff there to be alert and to work from Jazeera state. The finance, administration, and others are located in Port Sudan in the Red Sea state, and also from River Nile state we have another groups working there, and all these has administered and managed through some WhatsApp groups and so on. Next. Also, we have networking with many stakeholders, local and external potential partners to support the system. International organization, UN agencies, as Dalia mentioned, the Red Crescent and Red Cross, MSF, and others. Ministers of health in neighboring countries also, we managed to communicate with them, and we thank them a lot for their support in terms of the aids that they sent to Sudan. Also the diaspora, mainly the initiative of telemedicine. We have like a very promising telemedicine initiative now, in which we have more than 130 volunteers from different subspecialties and specialties, and we have selected like 4 hospitals. We see that they affected more, and they and the staff there can easily consult these consultants. These hospitals include in Khartoum, we choose 2 hospitals at Turkey and now hospitals, and from Jazeera we selected Al Kamlin hospitals in the northern part of the state, and also Amir Osman Digna hospital in Red Sea. These hospitals will be like the start, because we have in this initiative provider consultation, and also we have patient provider consultation. We started first with this because now we are concentrating on the provider consultation, and we expect to we expect this initiative to add more to the resilience of the health system in this stage and in the next stage, inshallah. Next. These are some challenges and areas availing the health services in Guinea, at the capital of West Darfur. I think now because this state is totally destructed, the healthcare service delivery is destructed completely in this state, and the availing of healthcare services there is top of the challenges facing the Ministry of Health. Also restoring the affected facilities in all the 6 states that are affected by war, availing the services for NCD patients in affected states, securing the supply of essential medicines and medical consumables, and lists are available. The master's list mentioned by Dalia are available for every entity that wants to help Sudan in this crisis. Also securing and running costs for all healthcare facilities, because as I said, the banking system and the is affected much, and also reimbursement of the staff. This is one of the because now you can imagine that 3 months now people working just like volunteer, because now no reimbursement, no paying for them at the health facilities level. Also availing the health services at cross-border points in Halfa, in Bor Sudan, in in Guinea, like the Abashi or that area where people crossing the borders, also one of the challenges to avail the services there. Also conducting the public health measures for IDPs, and I think this is one of the main challenges that we face. And all these are opportunities for the donors to help Sudan. I think by this I end my presentation. Next, please. Thank you very much.
Thank you so much. Thank you, Dr. Mughira, for your presentation, and thank you for expanding on Dr. Dalia's on the impact of on the healthcare system due to this crisis. One thing that's important, which you highlighted, is the efforts that has been exerted by the Federal Ministry of Health to mitigate those effects of such crisis. I know that there is one comment that says that dealing with public health emergencies and emergency during the 4 seasons is hard on its own. So we're sure that it's much harder with having this ongoing conflict. So thank you so much for providing this updates and your insights on the situation. With that, I move to our third speaker, Dr. Ali Raja. Dr. Ali Raja is a Pakistani national and professional medical epidemiologist, graduating in 2004 with a medical degree. He furthered his education by earning a Master's of Science in Public Health in 2010, with over 13 years of experience in the field of public health, specializing in disease surveillance and outbreak response. He devoted 9 years of his work in the international level. The majority of his professional career has been with the World Health Organization, spanning across various regions, and he also plays a crucial role in responding to 4 significant emergencies classified as WHO Grade 3 and ISC Grade 3, Level 3. Of them is the polio, Ebola, cholera, and most recently the COVID-19 outbreak. Recently, he is the WHO Sudan team lead for the epidemiology and health of the Health Information System unit since August 2022, and in his role he is actively involved in the Grade 3 emergency response in Sudan. Dr. Ali, please feel free to start your presentation. You have 20 minutes. Thank you.
So thank you very much, Asma. I would like to just start with thanking MFNet for giving me this opportunity to present, and I will complement what my senior colleagues, Dr. Dalia and Dr. Al Mugira have already stated. I will try to complement. So good morning, good afternoon, and good evening to all participants from wherever they are attending the webinar. Is my screen visible? Yeah.
Yes, thank you.
Okay. So my presentation is going to basically, as I've mentioned, I will try to complement what my senior colleagues have already explained in detail, but I will start with the pre-crisis situation, the public health situation before the conflict. Then I'll just be explaining the current situation after 15th of April. Then I'll quickly be going through what WHO as a UN agency, specialized agency for health, has been doing and what are the future plans for WHO. Few of the slides I just updated because Dr. Dalia mentioned about the disease outbreak. So I added few slides. So I'll try to cover, inshallah, within the allocated time. So this slide is basically giving us the situation, how Sudan public health situation looked before this crisis. We were experiencing multiple disease outbreaks, including the waterborne diseases outbreaks, the vector-borne, including malaria, dengue, vaccine preventable diseases outbreaks, measles, then COVID-19, Mpox, and recently in the last quarter of 2022, circulating vaccine-derived poliovirus 2 outbreak. Malaria, serious problem. It was a serious problem. It is still a serious problem in Sudan. In most of the weeks during the high transmission period, the epidemic threshold was crossed in majority of the states. And in the Eastern Mediterranean region, as per the World Health Report 2020, more than 50% of the cases and deaths from this region, they were reported from Sudan. Massive population movements, over 1.1 million of the refugees and asylum seekers in Sudan from various other countries, and a heavy load of IDPs, close to 3.7. Then, as per the multi-hazard plan, more than 75% of the localities, that is 141 localities out of 189 total localities of Sudan, they were identified as high risk for the 6 vital few hazards prioritized in the multi-hazard plan. The functionality of the health facilities, it was only 45% as per the information we had, with inadequate staffing and other resources. The disease surveillance system was very much fragmented. From the total sentinel surveillance sites showing coverage of only 34%. Apart from that, the 2021 survey for the selected health facilities showed just close to 31% of the essential medicines availability in those health facilities. Chronic malnutrition prevalence, stunting, acute malnutrition were posing serious issues. In terms of nutrition, close to 24% of the total population of Sudan, which is around 47 million in those 18 states, were facing high levels of acute food insecurity, that is the IPC phase 3 or above. The attacks on healthcare, this is a surveillance system on attacks on healthcare that WHO is monitoring globally. So from 2020 to 2023, just before this crisis, a total of 64 attacks with 11 deaths have been recorded with 42 injuries. So this was the situation before the crisis. Now coming to the situation after this escalation of violence started. As you can see on the right side, it's the map showing the total number of injuries and deaths reported through the Federal Public Health EOC. On 5th of June, WHO internal grading process, we graded Sudan emergency as grade 3 emergency. So grade 3 emergency is the highest level of alarm, in which internally all 3 levels of WHO are activated for full technical, financial, logistical, and operational support. Then as it started on 15th of April, we are over 2 months. over 1,000 injuries, over 1,000 deaths, and over 11,000 injuries. And 30% of these injuries and just over 20% of these deaths are reported from Khartoum. Till now, almost 18 humanitarian workers, including the healthcare workers, they have been killed, but this number is underrepresentative. The actual number might be very high. In terms of the health and nutrition services, as per the health cluster, there is a 50% reduction in the partner support to the health facilities. In Khartoum, as my senior colleague also mentioned, less than 1/5 of the health facilities are fully operational because they have so many constraints to run the operations. From 15th April through 20th of June today, 46 attacks on healthcare were recorded. So this is a serious issue, together with 8 deaths and 18 injuries. Over 100,000 children under 5 with severe acute malnutrition with medical complications, they need specialized treatment and care at the stabilization centers. Now, as per the HRP humanitarian response plan, over 1/3 of the population is in need of humanitarian aid. 4 million children and pregnant and lactating women, they are severely malnourished. Massive movements, internal displacements of over 1.6 million IDPs and over 500,000 individuals which have crossed the borders into the neighboring countries as per IOM. As the HRP is just over 17% funded, and for the health component, it is just over 11%, which is funded from total 2.7 billion, which is needed. The outbreaks are still ongoing, and the serious issues, they are the occupation of the National Public Health Laboratory. So no testing is ongoing in the country, and also the occupation of the National Medical Supply Fund, as also highlighted by Dr. Dalia, posing issues to the distribution of the drugs and other essential commodities. This slide is showing the health cluster partners support to the health facilities. So before the crisis, about 657 partners, they were supporting the health facilities with 100% functionality. But as this escalation of violence started, this support has dropped down to 50%, and the functionality status is still unknown. But we recently initiated the HIRAMS process, so which will give us a more clear picture in terms of the functionality of the health facilities, how many are fully functional, how many are partially functional, how many are not functional. So this process is also started. In terms of the HRP, its revision was done on 17th of May. Now it seeks 2.6 billion to help 18 million people in Sudan. It's only 17% funded for now. The health component of HRP seeks 178 million to reach about 11 million people in need. And it is also just over 11% funded. Overall, for HRP revision, there is a 57% increase in the people who are in need, 44% increase for the targeted population, and 47% increase in terms of the funding. And the target for health is mostly increased in Khartoum, where before the crisis there was very less humanitarian space present. And also the target increased in these Kordofan states, as you can see, North Kordofan and in South Kordofan. This slide is showing us the situation of the IDPs movements into within Sudan in the surrounding states. So you can see close to 1.6 million people have been displaced all over Sudan. And the highest number of displacements have been observed from West Darfur, which is close to 17%, followed by River Nile and northern states. The states from where these IDPs have been displaced, they are mostly displaced from Khartoum, West Darfur, South Darfur, North Darfur, Central and North Kordofan. 65% have been reportedly displaced from Khartoum state, which is the highest number of IDPs. They're coming from the Khartoum state. As you can see also the map on the right side, these arrows, they are mostly going out from the Khartoum state and going into Darfur state, into the River Nile, White Nile, and into northern states as well. In terms of the movement of the Sudanese into the surrounding countries, over 500,000 Sudanese refugees have crossed into the neighboring countries. 39%, that is over 200,000, they have crossed the borders into Egypt, followed by 28% into Chad, 21% into South Sudan, 9% Ethiopia, about 3% into Central African Republic, and less than 1% they have crossed into the borders into the Libya. In terms of the refugees and asylum seekers inside Sudan, as I highlighted in my first slide, about over 1.1 million refugees and asylum seekers from various countries, mostly from South Sudan. They were living inside Sudan, mostly in Khartoum, followed by White Nile state. Now, what happened that after the crisis, according to UNHCR, there have been a movement observed from these refugees and asylum seekers. Close to 175,000 individuals they have moved across Sudan. Mostly they're also coming out from Khartoum and going into White Nile. As you can see, the arrows, they're going into Red Sea, White Nile, Kassala, Gedaref, East Darfur, North Kordofan, and right now the majority of these refugees and asylum seekers, they are also coming from they are mostly South Sudanese, followed by various other nationalities, including Syria, from Ethiopia, Eritrea, and so forth. In terms of the refugees movements outside Sudan, the previous slide was showing us the movement of the refugees within Sudan. So now what is happening to outside Sudan, as you can see, as per UNHCR's data 6th of June, over 400,000 people have been, and these refugees and asylum seekers, they have crossed the Sudanese borders. And you can see close to 100,000, they have returned to their actual countries. So they are the refugee returnees going back to South Sudan, Central African Republic, and Ethiopia. In terms of the Sudanese refugees and asylum seekers, close to 300,000 people, they have crossed the borders into Egypt, Chad, South Sudan, Central African Republic, and Ethiopia. While the number of non-Sudanese refugees and asylum seekers which have crossed the borders into Egypt, South Sudan, and Ethiopia, it is close to almost 15,000 individuals. This slide is showing us the main key ongoing challenges as a result of this crisis. So what we have seen in the previous slides, we know now that the security situation is very unpredictable and fragile. There have been multiple attempts of ceasefire through starting after the Jeddah Declaration on 11th of May. Sometimes there was observation of the ceasefire that also resulted in significant transportation of the humanitarian aid to the Sudanese people. But in many cases, there was no respect to the ceasefire. So the security situation remains unpredictable. The movement and the passages of the patients, especially those who are injured going to the hospitals, as also explained by my senior colleagues, it's a concern. In many of the areas with the active conflict, they lost, the clean drinking water, and now we are also getting some alerts for the acute watery diarrhea cases. With the upcoming rainy season, the situation might be deteriorated. There are limitations and absence of sufficient human resources in the hospitals, and also issues related to the power cutouts, shortages of blood bags and oxygens, then the excess and transportation of the humanitarian aid, specifically to the Darfur states, Rainy season, I have already explained, shortages of fuels to run the operations of the hospitals, disruption of the banking system, affecting the cash flows, delays in the salaries of the government staff, some of the alerts for measles, AFP, dengue, malaria, and so forth. These are some of the challenges. So what is the main public health impact in terms of occupation of the National Medical Supply Fund? There's a risk of medication shortages. Also, the delays in the clearance processes of the supplies at the ports of entry, they're also posing risk for the shortages of these medicines. There is likelihood of different outbreaks, including cholera and vector-borne diseases. The disruption of the routine surveillance, including indicator-based, EVOS, community-based surveillance, specifically from the hotspot states. With the massive movements of the population, the states which are receiving these IDPs, they might be depleted of the resources, commodities, and services. So we are expecting demographic and epidemiological transition considering the current movement of these population. Significant reduction in the partner support, constraint in the logistics, movement of these supplies, specifically to the Darfur states, frequent attacks on the healthcare, exhausted and overstressed health system, the interruption of the vector control efforts. Although I understand, and Dr. Dali explained that the vector control activities, they started resuming, it's a very good sign. Risk of worsening, further worsening the malnutrition, the nutrition status of the population, the child psychosocial support and well-being. Over 3 million women and girls, they are facing increased risk of the sexual and gender-based violence. So these are some of the public health impacts. Now I'll just come quickly to what, as WHO, we have done so far, what we did before the crisis.
Dr. Raja,
yeah.
You have only 1 or 2 minutes before it's time to start the Q&A questions.
Okay.
If you can go over it very quickly, thank you.
I'll try to go very quickly. So before this start of crisis, we did pre-positioning of some drugs and supplies, specifically supporting the State Ministry of Health, Khartoum. So that proved very critical in the current situation, and those supplies were utilized. This slide is showing us how WHO is going to operate. We have our hubs located in Jazeera State, in Port Sudan, and cross-border, we have our core emergency team operating from Cairo, and we are also planning to operate from Chad, from Abache, so that we can cover these Darfur states which are not accessible. In terms of the response, the safety and security evacuation was carried out. In terms of the funding, you can see here, recently WHO finalized the health emergency response plan, which will seek $96 million for 1 year. And we have our regular incident management teams and incident management support team meetings ongoing between the 3 levels of WHO. Some of the supplies which were delivered to the states, including the trauma kits, interagency emergency health kits, and the operational support to the hospitals in collaboration with various humanitarian agencies, including MSF. Various nutrition supplies, you can see, as Dr. Dali also mentioned, that we delivered significant quantities of the nutrition supplies, that the SAM kits, they were provided to many of the kits to meet the needs of the nutrition. And we are expecting more supplies to arrive in Sudan very soon. We strategically identify 5 hospitals in Khartoum from where we provided the supplies to these hospitals, and you can see the blue highlighted hospitals are Shohada, Umbadda, Al Nau Hospital, Academia, and these hospitals, they were strategically selected by WHO, and we provided significant supplies to these hospitals, from where the supplies moved also to the other hospitals which were in need. The recent assessment of the surveillance, they identified surveillance system rapid assessment. They identified these major challenges, as you can see here on the screen. Majority challenges for the non-reporting, they are linked with the issues with the accessibility, the connectivity, the staffing, the operational costs, lack of refresher trainings, and lack of supportive supervision, depletion of some of the reporting tools, and so forth. And some of the immediate needs which can fulfill these which can fill these gaps for the surveillance in terms of the connectivity and internet provision for the devices, mobile credits, operational support to the rapid response teams, provision of the tools, and ensuring the supportive supervision visits. We submitted a proposal recently to revitalize the surveillance system to the Federal Ministry of Health, and His Excellency Dr. Haitham, the Federal Minister of Health, he approved. So with support of the federal and the state ministries and the health cluster partners, we are going to revitalize the surveillance in 3 phases, starting with the e-wards and the community-based surveillance, in also including the points of entry, and then also re-establishing the routine indicator-based surveillance. These are just some of the alerts which Dr. Dalia also mentioned, the various WhatsApp groups, the official WhatsApp groups between the federal ministries and the state ministries, the daily IBS alerts. You can see we are having measles, AFP, dengue fever, malaria, heat stroke. The community-based signals on a daily basis, they're also received. We started receiving from 21st of May. So these are the signals you can see mostly related to malaria, and some other signals related to shortages of drugs, animal bites, some fire incidents, the heavy rains indicating the upcoming rainy season, and so forth. These are just the upper bar graph is showing how many states. In the blue bars, you can see how many states they are reporting to the daily IBS alerts, and the lower bar is showing how many states are reporting for the community-based surveillance daily alert signals. So around 8 states are reporting daily for the indicator-based surveillance, and close to 10 states they are reporting for the signals from the communities. These are just the completeness rates for various states. Some of the activities from our Jazeera hub, the EOC is strengthened there, and the IDP's verifications is ongoing with UN OCHA. Multi-sectoral assessment conducted. We have 3 warehouses in Jazeera. It's a logistical hub, so we supply the deliveries from the Jazeera hub, and various hospital assessments are carried out from Jazeera hub. In terms of the response, these are just some of the response to the various alerts. As also mentioned by Dr. Dalila, the measles vaccination campaign in Blue Nile, starting with the active case searches in the IDP gathering sites in Jazeera state, and just responding to various other alerts and the signals received through the CBS. This is my second last slide. We are seeking from WHO Health Emergency Response Plan, which is final. For 1 year, we will seek $96 million. And 50% of this budget is required for the acute phase 1 for the first 3 months. And we have the priorities on the top, you can see on the right, giving priority to the life-saving supplies, essential medicines, addressing the trauma and emergency care needs, delivery of essential services, support facility-based care for nutrition, reinforcing the surveillance for timely control of the outbreaks, and also the health cluster leadership. This is the last slide.
Dr. Ali, we don't have any time for Q&A, so
okay, sure. So I'll just complete here. This was the pledging conference. $1.5 billion was raised in the recent pledging conference. So thanks very much for listening.
Thank you so much, Dr. Ali Raja. Thank you for your contributions. And we apologize for a very short time period. We just wanted to give some time for to ask a few of the questions. And we promise everyone who posted their questions in the Q&A that all the questions will be answered by our speakers. So I'll only pose one question to each of the speakers, and maybe later on we can answer the rest of the questions. So maybe one question to Dr. Dalia. From your perspective, there has been some questions in regards to what ways the crisis has affected or impacted the process of obstetrics and women giving birth in the most affected areas. And if you think there's anything that needs to be done or can be done to support this issue.
I think Daria is more suitable to answer this question.
Yes, yes. Dr. Daria?
Okay, thank you, Asma. I think just let me give wait.
We can move. It's okay, Dr. Daria. We can move to the next.
I'm very sorry.
Okay,
I
go
think okay. On the obstetrical newborn care, I think one of the main or the good opportunity that we have during COVID-19, because we already revamped what happened in the COVID-19 response. At that time during COVID, we invest a lot on the midwifery system, and also and specifically on the midwifery at the locality level. So the midwife chiefs have been a focal point for all the midwifery activities during that time of the COVID-19. So we just activate the same system where numbers, contact numbers of those midwifery chiefs in each locality have been distributed widely, and then women on the childbirth, they contact immediately for arranging for the child births at home deliveries. For the obstetrical newborn care, among services, I have mentioned that the 16 hospitals in Khartoum, now only 8 hospitals are working for maternity, and especially in the periphery of those states. The complicated or the very complicated deliveries will be referred to Jazeera or River Nile state. But I think midwives and the reproductive health staff, they done a very great job during this crisis. They have a very good coordination system to make this functional. Up to now, I think more than 200,000 deliveries has been normal deliveries have been implemented all over, and then 2,500 cesarean section have been implemented during the last 2 months in Khartoum state.
Thank you. Thank you so much, Dr. Dalia, for your answer. And thank you for participating with us today and providing all this information. Maybe a second question to Dr. Al-Mughira. There's a question saying that asking about the resource mobile clinics, if they are feasible in Kordofan and Darfur, given that the non-functionality of some of the health facilities there, of course, with the ongoing insecure situation. So if you can.
Yes, of course, I think this is one of the modalities that we use, especially in areas where the main jobs of the people there is the shepherd. They work at shepherd, and they go with their livestock for different areas. So we use this in in Kordofan region, the 3 states, also in Darfur states, where a lot of shepherds are there. But now really there is a need for that. People can use it for these areas, but usually these areas are not affected much by the conflict. The conflicts now, the crisis in the cities, in the towns, in the urban areas rather than the rural areas. This mobile clinics works well in the rural areas, and we have good experience with this. Even in Jazeera state, we use it in the peripheries, where the facilities are very few, and where people, as you know, that Sudanese people live in scattered villages with very few families there, that impedes the health system to construct and avail healthcare services for each and every population gathering. So this is the most, I think, suitable models, and we can make use of this, and I think it will be successful in these areas. Thank you.
Thank you so much. It seems like this is something feasible and it's already been
Yes.
implemented. So thank you so much for providing this insight. Maybe one last question to Dr. Ali Raja. Dr. Ali, with all the public health effects that you've mentioned from your side in regards to the impact of this crisis on public health, there were a couple of questions asking about how public health specialists are needed and can support within the realm of this conflict, as well as if there's anything else that other national and international organizations can support with in regards to the public health effects of this crisis.
Yes, thank you very much. So right now, whenever such crisis happens, Sudan was also a grade 2 emergency before even start of this violence. And right now, as I mentioned in one of my slides, that this emergency internal WHO grading process has graded Sudan emergency as grade 3, which is the highest level of alarm for any public health emergency. Now, what we are doing is that we are coordinating to all health partners to the health cluster platform. On a weekly basis, the Sudan Health Cluster is organizing the online sessions. Last week, even the online health cluster coordination meeting was chaired by His Excellency, the Federal Minister of Health. So in that forum, all UN agencies, also the international INGOs, we discuss these issues in terms of what response activities have been carried out, where are the gaps, and what are the needed support. In terms of the public health specialists, first of all, I would like to salute the Sudanese doctors community, the doctors and the nurses who are really endangering their lives and working day and night in the most complex situation. I really salute and I pray for them. We of course, as I mentioned, we have our hubs, one in Jazeera, one in Port Sudan. And in those hubs, of course, as we are proceeding, we will be requiring, and we might be advertising some positions for various technical expertise, and we will require the support of the Sudanese colleagues, and everyone is most welcome to apply. And of course, those will be through the competitive process. So I think we are all working as one humanitarian community under the leadership of the government and the Federal Ministry of Health, within the states under the leadership of the state ministries of health, which are also through these public health emergency operation centers, which are operational. They are convening these meetings of various partners that are coming and discussing the response issues and challenges at the level of the states. And this will continue, and inshallah, we will improve further in the days to come. Thanks very much.
Thank you so much, Dr. Raja, and we apologize for all the participants who have submitted their questions. We promise that we will coordinate with our speakers and we will respond to your questions. And I want to second what you said, Dr. Ali Raja. We raise our hats to all the healthcare workers and workers who are currently working to alleviate some of the impacts on the public health or health situation in Sudan. We thank them for everything that they do, and we pay them all the respect in regards to the efforts that are being conducted. And with this, we conclude our webinar on Sudan crisis and its impact on health. Our hearts, with everything that we listen to, are heavy with this weight of all the effects that are being endured by Sudan. But we hope that the situation will be better, inshallah. And we encourage ourselves and encourage everyone to maintain this momentum beyond even this webinar, to stay informed and engaged in regard to all types of support that can be provided to support Sudan's health situation. So with this, I would like to thank everyone for your commitment and time and dedication in this webinar. We thank our distinguished speaker for being with us here today and taking the time to provide these updates. So thank you so much for that. I wish everyone a good night. Thank you so much. Thank you so much, everyone.
Thank you. Thank you very much. Thank you.
Thank you very much.
Thank you very much.